Okay, it's great to see you all. Thank you very much for inviting me. Denise, about 2 months ago, so I know a little bit about snowmen, so it's fascinating. And it's something we're going to be looking into, like the Genomes project as well. Okay, so I mean, I've entitled it Pioneering Informatics at UHB. It sounds very jazzy, but I think what I'm looking at it is the application of informatics in terms of, yes, in terms of looking at the interoperability and the integration of systems. But I'm actually going to be running through to you some real-life projects that we're running now that take the principles of integration and interoperability, bit of a mouthful, and thus you'll see the kind of things that we're using at UHB. So I'm going to briefly look at our core business and then show you some of the tools we use for evidence-informed practice in terms of research, a couple of benchmarking tools as well that we've got going on now, and then 2 tools which enable patients to be engaged in informatics as well, and then briefly right at the end, if I have some time, talk about genome sequencing. So I'm going to go for all that. That's about our capability. I mean, it's broadly speaking, we're in the business of data collection, managing data and linking data sets. We are blessed with quite a large range of data systems at UHB and clinical systems. We have the prescribing information comm system, PICS, which has been around for about 5 or 6 years now. We have our own PAS, we have our own lab systems, theatre systems. So lots of data systems with huge potential for us to be able to link those, and beyond that as well, for us to be able to utilise data locally, nationally and internationally. We do a lot of work with information security and governance. We develop partnerships with HSCIC and partnerships in the private sector as well, such as KPMG, especially when we're developing our benchmarking tool. We're heavily research active, and I'll show you a couple of tools that we're using at the moment. And we have our own quality and outcomes research unit, which is all about developing local indicators using the data systems at UHB to be able to provide clinicians with meaningful insight into what's happening in their service or their specialty. And as well, I'll show you later that the informatics consumer systems, one such would be My Health at QEHB. So it's all very well us being able to do these really cool, exciting things in terms of developing something like My Health at QEHB. But before we do any of that, we're really big on the idea of getting our own house in order first before we do that. It's exciting doing that work, great, but we need to be doing our bread and butter work first. So we classify this as our core business. This is the dashboard that's on all of our desktops at UHB, and it's that clinical dashboard which talks to PICS. And essentially it gives nurses or any medical staff or any of the operational staff in their ward the opportunity to be able to continually monitor in real time the clinical quality and the safety factors for their patients. So it works in a pressure gauge format. You've got a comparison against the trust over the last 6 months, and you've got such indicators such as infection control, adverse events, medicines management. And behind this as well, the developers have developed automatic alerts, which are rules-based, which enable clinicians, nurses, etc., to be able to notify of any specific scenario. So say, for example, the patient comes into hospital and based on a certain rule set, they're supposed to be prescribed a certain type of drug within 48 hours of being admitted. We developed rules to be able to notify specific teams within a specialty to alert them if that drug's not been prescribed. And there's a whole host of other types of rules that we can build as well, so it is quite endless in that respect. Continuing from our core business, we have other dashboards for the likes of our emergency department. Stroke have their own dashboard as well, and we also have as well the local KPIs that we develop for the quality and outcomes research unit. The HR department have their own dashboard to look at things such as compliance with training, agency, spend, and a whole host of other indicators as well. And underpinning that, we have a team that are specialised in SQL, and that enables them to utilise the various systems and link data for the likes of PICS, PAS, theatre systems and labs. I mean, that's just 4. There's literally about 40 systems I could list, but I don't want to bore you to death with all of that. So it is underpinned by that ability to be able to interrogate data using structured query language. So that's our core business, which when we get right, it enables us to be able to look at the more interesting side of informatics, such as research. There's 4 areas that we can look at, but I'm just going to look at data sampling and collection tools and international benchmarking. This is our clinical trial screening tool. I could have got a much better screenshot about that, so apologies for that. But our clinical trial screening tool essentially is an application which allows the research team in UHB to be able to identify patients that are eligible for a clinical trial. Before this came about, and you'll probably know, some of you are involved in research, it takes an incredible amount of resource and time to be able to identify a patient which might be eligible for a clinical trial. A patient comes into hospital, and also the last thing they might want to be asked is, do you want to be involved in this clinical trial? They're quite distressed already. All they care about is getting better and going home and being safe. This clinical trial screening tool is linked to the likes of our prescribing information comm system, PAS, our lab system, and based on, again, certain rule sets, it's able to interrogate and identify specific cohorts of patients which a research nurse could approach to see if that patient is interested in a clinical trial. The outcome of this is that we're not approaching patients unnecessarily, saving them the stress or the embarrassment of saying possibly no. It's allowing the research team to be far more targeted in their recruitment strategy, and it's also enhancing recruitment as well. I think since its inception, the renal specialty have been able to electronically, without even approaching any patients, look at the potential. I think it's about 5,000 patients. That was without even approaching them, just by looking at the data behind it. So that's made quite a big difference in that respect. From another point of view, we develop applications which enable the likes of the SRMRC, or Surgical Reconstruction Microbiology Research Centre, so another large mouthful there, to again look at trauma-related trials. So a similar kind of thing here, developing rules-based applications which enable or facilitate the whole process of clinical trials management. This one is slightly different in that it enables us to develop protocols which, for example, identify when a patient should have their bloods, when an X-ray is required. But this tool also enables them to, once the patient is actually recruited to the trial, it enables the research nurse or the other research teams to be able to manage the whole recruitment process. So updating the patient in terms of progress, logging any trials they've been involved in, logging any interaction between the patient and the clinical team. On top of that, it also manages the consent process. There is a massive need to be able to have that in there because from a governance perspective, you need to be showing complete transparency in terms of, have you actually got complete consent from that patient? Or have there been any layers within that consent to say that the patient's happy to be involved in X and Y, but not in Z? So the application does allow for that. And it's, the CREST tool is also more orientated on managing tasks for the research team as well. And it is scalable. Yes, it is for the trauma team, but it is scalable and it can be transferable to other specialties as well. The way it works, the rules-based system, is that it can be applied to another specialty. They can pick it up and engaging with us, we could create new rules for you specific to your own clinical trial. Any questions so far on research tools? Okay, cool. Benchmarking. There's 2 types of benchmarking I want to talk about. The first one is IHB, or International Hospital Benchmarking. This is exactly what it says it is, really. If you imagine a tool which utilises the equivalent of HES data, but in another country, brings all of that data together and enables your hospital to be able to benchmark your performance against 6 other countries in the world. And this is what this does. So it enables you to compare against things like quality aspects, clinical safety, and the efficiency of your healthcare delivery. And you can also compare your outcomes against the outcomes of other patient groups in other hospitals as well. It utilises the equivalent of HES data in those other countries, but the one commonality between this is that it's using the common denominator of ICD-9 and ICD-10. Users are able to select peer groups relevant to them, so if you've got a certain specialty, you can analyse that specific area of your specialty and compare performance with other hospitals. You can even go down deeper into level if you just purely want to look at hospitals within the West Midlands. You can do that as well, that's fine. But it's enabling you to kind of look from a much wider perspective, not just England. We've got 6 countries involved now, not 5. Netherlands, Australia, USA, Germany and Italy. The Czech Republic are involved in us as well. And we do have interest from the likes of Norway and Belgium as well. So the more countries we get on top of this, the more sort of benchmarking we'll be able to do. Okay, I think we've got about over 350 hospitals involved, and obviously the power of that is that you're able to benchmark on a much wider scale, and the drill down possibilities are very scalable as well, so you can compare against hospitals, look at different diagnoses, different types of intervention. It is endless, and not only that, you can export the data and manipulate it in your own way in Excel as well. The other tool that you're probably more aware of is HED. Are there any hospitals in here that are actually signed up to use HED? Massive hands going up there. Okay, so this is our healthcare evaluation data tool. We have around about 40 acute trusts signed up to using this, 3 clinical commissioning groups, and we have the Australian Healthcare Round Table as well using this. The fuel of this is HES data. It basically enables you to benchmark your performance, just looking in England now, not internationally. Benchmark your performance from a clinical quality, a safety and an operational efficiency perspective just in England. It's developed by the NHS for the NHS. It's clinically led, it's a transparent system that enables you to look at things like efficiency gains, any clinical outcomes. There's a financial module in it too, which enables you to monitor your contracts. And it is clinically led in its design. So I think something similar to it would be the equivalent of something like Dr. Foster. The big difference with this is that it's not producing sensationalist reports in the Sunday Times every year. You can choose to perform your own analytics on it, it's completely confidential. And it has features which enable you to point, click and drill through the analysis and extract tools to carry out investigations pertaining to your own hospital. It's also a rules-based system, so you can develop your own rules in there to give yourself automatic notifications. So if there's any areas of performance which are going below an expected target, you'll get automatic notifications sent out to specific operational team members or clinicians. And it does have quite advanced statistical methods to identify any outliers on a certain type of indicator. Okay, any questions about benchmarking HED or IHD? Hello?
Just on HED, are those data only visible to participants within HED?
That's right, yes, yes. But sign up to it is extremely easy. If someone's interested in signing up, they can come to me or speak direct to the HED team. There's a website with a demo as well, which is right at the end. I can share the presentation with you. You can have a look with your heart's content.
I guess I was thinking about really the connection with that next bit,
yeah.
Which is to what extent where those data coming out from HED
yeah.
have got a value to informing quality assessments.
Yeah.
Are there any plans for a cleansed version or a sanitised version of those data to be visible externally?
For the purposes of patients and commissioners and etc.
Patients, industry.
Yeah. I mean, we are. It comes on at a good time because I'm going to show you bits of that anyway. But we are already actively working with the likes of the CCG to make what HED produces totally visual, and we're even building our own kind of clinical commissioning group version of HED purely for a CCG. So they've got something similar to it, but they can do their own analytics using their own tool. So it's a yes, essentially, yeah. But what I'm going to talk about now, you'll get a feel for how else we're doing that as well. Could start at my stay at QHB. There's a bit of a pattern here. It's something like my stay at QHB, my health at QHB, so you spot the pattern. So this is all about enabling patients to be able to know what the performance is of the hospital before they come for an operation. And it's doing a very, very similar thing. Instead of actually, it's talking to the PIC system here. So this example, you can actually go on our website right now and you can find out for cardiology, how do they perform in delivering timely interventions. And there are other types of things as well. So they can find out what was cardiology's score in the patient experience. How did cardiology fare in delivering procedures within the expected time frame, etc., etc. Not only this is that we've made it kind of patient friendly by giving you some information about what it means, that what the actual data is that they're looking at, what it actually means. And there are some indicators on there. I can't show you live on the website now, but they can look at it from a consultant level as well, so they can get a feel for which consultants are actually residing in cardiology and what's their individual performance as well. So this is all about empowering patients and giving them a feel for the quality of the service before they even turn up at the hospital as well. My Health at QHB, this is a program that I manage, very close to my heart, and something that we're working with the AHSN on at the moment. We had a very generous funding from AHSN to be able to develop the portal and also to be able to package the learning from My Health at QHB that we've had for the last 2 years now since it's gone live, and be able to share that with the likes of you and other providers in the West Midlands and beyond. So what is My Health? Essentially it's a portal, an online portal, which gives patients the ability to be able to view and control their health record online. They can see their medications, any lab results, any blood results they've had at UHB. They can see their entire inpatient history, both retrospectively and prospectively. They can get access to any useful information about their specific treatment or their condition. They can look at any hospital appointments they might have. They can, if they want to, contact a medical secretary or consultant. And they can also upload any type of information to the portal as well, if they want to. And they can also choose to upload information to their vault and choose to share it with a specific consultant. So a good scenario would be if you had a patient who lived in Oswestry, who did like coming to Birmingham but felt, I'm feeling a bit tired, I don't really fancy going to Birmingham today. I know I've got an appointment coming up, and I know in that appointment it's quite a big deal about my blood results, and I know that I might not have to actually go to the hospital if my consultant knows what those blood results are. So quite conceivably the patient could upload the results of their blood results that they had at their local GP or their local hospital, choose to share it with a consultant here at UHB. They could review that, and we have had instances where the consultants reviewed it and contacted the patient and said, you know what, looked at your blood results, it's okay, you don't need to come in, it's fine. They're happy and contented that that's what they were going to look at in the appointment, and it's okay, so they don't need to come in. So very, very handy for patients with long-term chronic conditions, because they're more likely going to be looking at their health record, and also handy for patients who have to travel quite a long way as well. Going back to the AHSN funded work that we're involved in, that enabled us to be able to develop a care plan for renal patients. So we have what we call the MARS system, which is a specialist database system which enables patients to be able to look at and track out information specific to renal. We're also piloting virtual clinics, so patients will be able to have video conferencing with their consultant in the comfort of their own home. And a big push on this as well is to be able to package My Health and be able to show the likes of yourselves and other hospitals, right, this is how we would go about integrating something like the My Health at another provider as well. How much time do I have? Am I okay, yeah? Okay. You gave me the look then.
Yeah, I know.
Okay.
Quickly.
Sure, yeah. How many have I got left? Okay. Super Scheduler, I'll be brief on this one. This is a pilot we're doing with liver. At the moment, events comprising a patient pathway all tend to be booked in isolation. So if a patient turns up at hospital and the doctor knows exactly what it is they're going to have, at the moment, all of these events leading to that procedure will all be booked in isolation. And there's loads of different scheduling systems involved in this. So what Super Scheduler aims to do is basically enable all events comprising comprising a pathway to be booked simultaneously. The benefit of that is that a patient can walk out of an outpatient appointment knowing the exact date and times of every single event culminating to the procedure they're going to have. Quite a challenge because there's different clinical systems which provide the dates and times of these. So PAS, for example, will provide the follow-up clinic date. You've got an imaging system which provides the date for consistent tomography. And then you've got another system which provides dates and times for the MDT to happen, for example. So an application we're developing here which enables simultaneous booking in one interface, so the nurse or the doctor is not going to have to go into different systems to book all of these events. Right. And a final word on electronic sampling tracking tool. This is a portal which enables you to be able to track and store samples that are ultimately being released for biomedical research. And basically, patients are entered on a database. It's linked to their electronic patient record. You can pull down a large amount of clinical information for each donor, and the results of any genetic testing, which is carried out by a neighbouring trust, are automatically pulled back onto the portal. The reason I mention that is because it relates to the Genome project, which is going to be launched in February time, where we're hosting, alongside 8 other hospitals in the West Midlands, the genome sampling collection, which is the commitment to collect 10,000 genomes within about 3 years. And we're going to use the electronic sampling tracking tool as a platform for that. And we're going to be adding functionality for SNOMED as well to do that. So, thanks for listening. If you need to talk to me about any specific matters on the presentation, probably the best point of contact for that. If you need to speak to anyone about HED, we've got our own email address here for that, as well for the international benchmarking tool as well.